Thank you for joining today's web interface support call for ACOs, groups, and virtual groups. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone in the support call questions box. And CMS Subject Matter Experts will address as many questions as time allows. Also, to note, a recording and slide deck from today's call will be posted on the QPP webinar library within the next 2 weeks. Now I'll turn it over to Dan Herman at CMS to begin.
Thank you, Olivia. Welcome, everyone, and thank you for joining us today as groups, virtual groups, and ACOs prepare for quality reporting. I'm Dan Herman from CMS. Joining me on the call today are other CMS experts and contractors who will share helpful information on CMS Web Interface quality reporting and answer your questions following today's presentation. Today's call will only focus on 2022 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Today's slide deck, recording, and transcript will be available on the QPP webinar library within the next 2 weeks. Next slide. This is a disclaimer slide about this presentation. Information in this presentation is current at the time it's published, but I urge you to please be sure you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program or Shared Savings Program ACO regarding any updated information. Next slide, please. Then we're going to talk about announcements and reminders. Next slide. The CMS Web Interface will close at 8 p.m. Eastern Time on March 31st, 2023. Your submission will be automatically accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. Here is a list of the upcoming support calls. The next support call will be held Wednesday, February 8th, 2023, from 1 to 2:30 p.m. Eastern Time. And the topics will cover frequently asked measure questions regarding the following topics: HTN2, controlling high blood pressure; Prev 13, statin therapy for the prevention and treatment of cardiovascular disease. Additional topics may be added prior to the support call. Next slide, please. The 2022 CMS Web Interface measure specifications and supporting documents were posted on the QPP Resource Library in December of 2021. This includes the release notes outlining the changes that were made between the 2021 and 2022 performance periods. Substantive changes were made to all 10 measures. Next slide, please. The CMS Web Interface API is available all year for testing in the developer preview environment. Please review the links listed here for more information. Next slide, please. 2022 is the final performance period for MIPS groups and virtual groups to report using the CMS Web Interface. Transition resources are available on the QPP Resource Library and the QPP Webinar Library. The CMS Web Interface will remain an available collection type only for Medicare Shared Savings Program ACOs reporting via the APM Performance Pathway, otherwise known as the APP, for the 2023 and 2024 performance periods. Next slide, please. Next, we're going to talk about extreme and uncontrollable circumstances exception. Next slide. If you believe you've been affected by an extreme and uncontrollable circumstance, such as the public health emergency triggered by the COVID-19 pandemic, you can apply for a 2022 MIPS Extreme and Uncontrollable Circumstances, or EUC, exception, regardless of whether you report traditional MIPS or APP. Extreme and uncontrollable circumstances are defined as rare events entirely outside of your control and the control of the facility in which you practice. These circumstances would cause you to be unable to collect information necessary to submit for a MIPS performance category, cause you to be unable to submit information that would be used to score a MIPS performance category for an extended period of time. For example, if you were unable to collect data for the quality performance category for 3 months and or impact your normal processes, affecting your performance on cost measures and other administrative claims measures. Next slide, please. Groups, virtual groups, and APM entities have an opportunity to submit a 2022 MIPS EUC exception application requesting reweighting for any or all performance categories for the 2022 performance period. CMS has extended the 2022 MIPS EUC exception application deadline to allow individuals, groups, virtual groups, and APM entities to submit an application requesting MIPS performance category reweighting due to the ongoing COVID-19 public health emergency. 2022 MIPS EUC exception applications citing COVID-19 as the triggering event can be submitted until 8 p.m. Eastern Time on Friday, March 3rd, 2023. If a 2022 MIPS EUC exception application is approved, but a group later determines that it's able to collect and submit data, a group that submits data at the group level for the 2022 performance period will be scored as a group according to the existing and applicable 2022 MIPS scoring policies. A virtual group determines that it is able to collect and submit data. A virtual group will be scored as a virtual group according to existing 2022 MIPS scoring policies. And you can find information about the 2022 extreme and uncontrollable circumstances exception application in the 2022 MIPS extreme and uncontrollable circumstances exception application guide linked on this slide. Next slide, please. All ACOs and their beneficiaries are impacted by the PHE under the Shared Savings Program EUC policy for performance year 2022. ACOs that report quality data via the APP and meet MIPS data completeness and case minimum requirements will receive the higher of their ACO's MIPS quality performance category score or the 30th percentile MIPS quality performance category score for purposes of determining shared savings. ACOs that are unable to report quality data via the APP will have their ACO quality performance score set equal to the 30th percentile MIPS quality performance category score for purposes of determining shared savings. Now I'll hand things over to Katie Moore, who will review other CMS approved reason requests and frequently asked measure questions.
Thank you, Dan. Next slide, please. So when speaking about other CMS approved reason requests, some patients may be skipped because they don't qualify for a given measure or for the sample. Each measure specification displays a list of the specific reasons why a patient might not qualify for the measure. Requesting an other CMS approved reason is a way to skip a patient attributed to a measure during denominator confirmation. This specific reason is reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or exceptions identified in the measure specs. These are submitted through the CMS Web Interface, and we request that you provide detailed information about why the patient should be skipped. It isn't necessary to request an other CMS approved reason if there's an applicable denominator exclusion, an applicable denominator exception, or if the patient is not qualified for the sample. These are instances where the patient is deceased, in hospice, moved out of the country, or didn't have fee-for-service Medicare as their primary payer. These can all be reported through the CMS Web Interface separately from an other CMS approved reason. In addition, we would like to note that the following requests will be denied. For Tier 2, requests to skip non-ambulatory patients will be denied. The denominator exclusion for non-ambulatory patients was removed for the 2022 performance period. The expectation is that all patients are screened for fall risk. Next slide, please. Once submitted, additional information may be requested from the submitter via email from the PIMS Quality Measure Support mailbox. These are sent to the address entered by the submitter in the skip request. We ask that you reply with the information requested as soon as possible. For any questions, you may contact qpp@cms.hhs.gov if you need additional follow-up related to the skip request you submitted. If multiple requests for additional detail are unanswered, the request will move forward in the review process using the information available. Once a decision has been issued, the request can't be reopened. If another CMS approved reason request is approved, the patient will be skipped and another patient must be reported in their place for the measure if available. If the request is denied, the patient will remain incomplete until you complete reporting on that patient. Please note that when submitting an other CMS approved reason during the last days of submission, this could cause your request not to be processed. We ask that you submit requests as soon as possible. You can find more information on how to submit another CMS approved reason request in the 2022 CMS Web Interface User Guide on page 52. Next slide, please. Now we'll review frequently asked measure questions. Next. The first topic we're going to discuss is 2022 telehealth and the applicability when reporting CMS Web Interface measures. For numerator compliance, a telehealth encounter may include medical information obtained over the phone, email, or other electronic communication used to interact with a patient. Telehealth encounters for the CMS Web Interface aren't limited to billable Medicare telehealth visits. It's important to reference the measure specifications to determine if medical record information captured during a telehealth visit counts toward performance. If the quality action of the measure is captured during a telehealth encounter, medical record documentation is required to support what's reported within the CMS Web Interface. All 10 of the 2022 CMS Web Interface measures allow for numerator compliance during a telehealth encounter. Please refer to the 2022 CMS Web Interface Telehealth Guidance document on the QPP Resource Library for more information. Next slide. Okay, now we're going to discuss the measure PREV-12, Preventive Care and Screening for Depression and Follow-Up. The intent of this measure is to screen patients aged 12 years and older for depression, and if positive, document a follow-up plan. As it relates to the use of telehealth, screening for depression may be completed during a telehealth encounter, and documentation of a recommended follow-up plan for a positive depression screening may be completed during a telehealth encounter. Next slide. Some of the frequently asked questions we receive are listed on this slide, so we will walk through those. So question number 1 is, previously a follow-up plan had to be documented on the date of a positive screen, but for the 2022 measure specifications, it states it must be documented on the date of the eligible encounter. Is that correct? The response is yes. For the 2022 CMS Web Interface PREV-12 measure, a follow-up must be documented by the date of encounter, either a telehealth or an office visit. Question 2, what is considered an eligible encounter for the 2022 PREV-12 measure? In this instance, the quality action isn't limited to a specific encounter type to meet the intent of the measure. You may use the Encounter Codes tab of the PREV-12 coding document as a reference for the encounter types, but the numerator action isn't limited to those encounters. Question 3, can documentation of a follow-up plan be used to infer a depression screening was positive if no results were documented? The answer is no. A clinician's interpretation of the results is required and it must be documented in the medical record. Question 4, does conducting a PHQ-9 after a positive PHQ-2 count as appropriate follow-up for the measure as it has in the past? The response is no. Per the 2022 PREV-12 measure specification, additional screening and assessment during the qualifying encounter doesn't qualify as a follow-up plan. Next slide, please. Question 5. In the 2022 PREV-12 measure specification, the denominator exclusion was revised such that the word active is no longer present. Does that mean that one of these diagnoses at any point in the patient's history would exclude them from the measure? The answer is yes. The exclusion is no longer limited to patients with an active diagnosis of depression or bipolar disorder and includes patients with any history of these diagnoses. The measure language and denominator exclusions were updated to reflect that this measure is screening for depressions for patients who haven't been previously diagnosed, or have an active diagnosis of depression or bipolar disorder. Question 6. The 2022 PREV 12 measure specifications state the screening results must be reviewed and verified and documented by the eligible professional in the medical record on the day of the encounter. What is the definition of an eligible professional? The 2022 PREV 12 specification states the results must be reviewed/verified and documented by the eligible professional in the medical record on the date of the encounter to meet the screening portion of this measure. The intent of this statement is to clarify that the quality action should be completed by an eligible clinician. However, others within your organization may complete the quality action. It can be completed by anyone the organization considers qualified. Next slide, please. Question 7, does a certain condition, for example, intellectual disability, impairment, Alzheimer's disease, dementia, or autism, qualify a patient for a denominator exception or exclusion? The response is that the denominator exclusion only applies to patients who have been diagnosed with depression or bipolar disorder. The specification doesn't define denominator exceptions by specific diagnosis. If the patient qualifies for the measure and there's medical record documentation that the patient wasn't screened for depression due to a medical reason, then it would be appropriate to select the denominator exception. Next slide, please. Now we'll review HTN2, controlling high blood pressure. The intent of this measure is for patients 18 to 85 years of age who had a diagnosis of essential hypertension starting before and continuing into, or starting during the first 6 months of the measurement period, and whose most recent blood pressure was adequately controlled during the measurement period. In regard to the use of telehealth, a blood pressure reading may be taken either by a clinician or a remote monitoring device and conveyed by the patient to their clinician during a telehealth encounter. Next slide. Some of the frequently asked questions we receive are, number 1, what is the definition of a remote monitoring device? The specifications don't define a remote monitoring device. It's the clinician's responsibility and their discretion to confirm the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. Question 2, is it acceptable to submit a blood pressure average? For example, average of 2 or more blood pressure readings taken in the same visit. The response is no. The measure requires the most recent blood pressure documented within the medical record during the measurement period be reported for the numerator. We suggest you see page 10 of the 2022 HTN2 measure specification for the following guidance. If there are multiple blood pressure readings on the same day, use the lowest systolic and lowest diastolic reading as the most recent blood pressure reading. Question 3. Is the blood pressure reading taken during an urgent care visit acceptable to use for the numerator if it's the most recent blood pressure documented during the measurement period? The response is yes. Urgent care coding is present within the Encounter Codes tab of the 2022 CMS Web Interface HTN coding document. Therefore, blood pressure values from urgent care encounters should be included if they're the most recent. Next slide, please. Question 4, should a blood pressure value from an emergency department encounter be used if it's the most recent? The response is no. Page 10 of the 2022 HTN2 measure specification guidance states that blood pressure readings taken during an acute inpatient stay or ED visit shouldn't be included. Question 5, can we accept patient-reported blood pressure readings? The response is that only blood pressure readings performed by a clinician or remote monitoring device are acceptable for numerator compliance. This includes blood pressures taken in person by a clinician and blood pressures measured remotely by electronic monitoring devices capable of transmitting the blood pressure data to the clinician. Blood pressure readings taken by a remote monitoring device and conveyed by the patient to the clinician are also acceptable. It's the clinician's responsibility and discretion to confirm the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable and whether the blood pressure reading is considered accurate before documenting it in the patient's medical record. Don't include readings taken by the patient using a non-digital device, such as with a manual blood pressure cuff and its stethoscope. Next slide. That concludes our frequently asked questions. I'll hand things back over to Dan to cover the resources and where to go for help. Thank you.
Thank you, Katie. These next few slides will outline the available CMS Web Interface resources. Next slide. Please note that 2022 submission resources are available on the Quality Payment Program Resource Library. We encourage you to review these documents if you have questions on quality requirements and measures. We'll continue to communicate any future postings on upcoming support calls. Next slide, please. For those transitioning to another collection type for the 2023 performance period and beyond, resources are available on the QPP library and QPP webinar library. Next slide, please. Finally, this slide contains links to resources available for Shared Savings Program ACOs. We encourage you to review the materials available here for more information. Next slide, please. And if you need additional assistance, please refer to the contact information listed on this slide. Now I will hand things over to Olivia to begin the Q&A.
Thank you, Dan. All right, so we are now going to start the Q&A portion of today's webinar. And just a quick reminder, you can ask questions via the Q&A box, and we can see that some folks have already done that, which is great. But you can also ask a question through the webinar audio. So to ask a question live, please raise your hand and we will unmute your line so that you can speak. Just another reminder, if you do want to submit a question via the Q&A box anonymously, please click send anonymously. Otherwise, all attendees will be able to see your question. Okay, we will get started with some questions that we have already received. The first question reads, Prev 12, what is meant by eligible encounter/appointment? Our care coordinators are calling and performing the depression screening via telephone.
Hi, this is Katie from the PIMS team. So if we can take a look at slide 19. Thank you. So this is addressed in question 2. So the quality action here isn't limited to a specific encounter type to meet the intent of the measure. So you can use the encounter codes tab of Prep 12 as a reference, but really that numerator action isn't required to be completed at a certain type of encounter. In terms of the use of telehealth, as we sort of addressed in the presentation, the telehealth encounters for the CMS Web Interface aren't limited to those billable Medicare telehealth visits. So any medical record information obtained over the phone, email, or other electronic communication used to interact with the patient are considered acceptable to meet the numerator of this measure. Thank you.
Thank you, Katie. And we did receive another question that says, is there a new question and answers document for this year?
Yes, so if you navigate to the QPP website and visit the resource library, the 2022 FAQ document is posted on the resource library. If you search web interface or FAQ, it should come up right away, but if you have trouble finding it, we can also send a direct link out to that.
Great. And the next question, does it have to be a televideo with audio for PHQ-9 to be done via phone?
So this one sounds similar to the last one, but just to reiterate that the web interface definition of telehealth is less stringent than for other collection types within the program. So They are not limited to billable Medicare telehealth visits and can include phone, email, or other electronic communication used to interact with the patient. We just want to emphasize that the quality action and documentation must be outlined in the medical record in order to support the information that's been reported. Thank you.
Great. And the next question, non-ambulatory was removed as an exclusion. So am I correct to understand that if it is documented in the fall screen tool, it counts as a fall screen performed?
And this is Deb from the PIMS team. The expectation is that a fall screening is completed during the measurement period for each eligible patient. And in this case, because that exclusion was removed, there is the expectation that a fall screen is completed. Thank you.
Great. And then someone asking for clarification on around falls risk. And it says, so if you are saying if the patient uses a mobility device such as walker, wheelchair, etc., does that mean they are not excluded from the fall risk measure?
And that is correct. They would not be excluded from the falls measure. There should be a falls risk assessment that is completed and documented.
Perfect. The next question is about PREV 12, and it says, is there a depression screening with a score of 0? Would this be considered a negative result?
So when submitting data through the CMS Web Interface, it's expected for groups, virtual groups, and APM entities to retain supporting medical record documentation demonstrating that the patient met the denominator criteria, the numerator quality action was performed, and that any applicable denominator exclusions or exceptions existed. So in this scenario, due to the comprehensive and individual nature of patient medical records only available to CMS Web Interface users, CMS can't provide specific feedback regarding whether or not specific documentation would meet the intent of the measure or suffice in the event of an audit. So we encourage you to review the 2022 PREV 12 measure specification and ensure your documentation supports that all components of the measure have been met. Thank you.
And the next question says, by the date or on the date of the encounter for a depression screen follow-up plan. And then
Sure.
they just asked if you could clarify.
Yep. So yeah, we do understand that the language in the FAQ document and in the presentation today is a little bit different using that by the date of the encounter. This is just to account for the fact that the quality action doesn't specifically need to be tied to a certain encounter type as the specifications are currently written. So the guidance is to ensure that the follow-up plan is documented by the date of the encounter, given the 14-day window. So just a little bit more flexibility in the language instead of specifying that it must be on the date of the encounter. Thank you.
Great. The next question, for any of the metrics where a diagnosis is having to be confirmed, is the diagnosis being on the patient's active problem list enough to confirm the diagnosis, or does there need to be a progress note documentation about that diagnosis?
Hi, this is Angie from PIMS. There is a definition of active diagnosis in some of the specifications, such as the diabetes measure or the MH1 depression remission at 12 months. And they do define that. The measure specifications really aren't prescriptive as to how you have to document an active diagnosis, but it does define it as it's either on the patient's problem list, a diagnosis code listed on the encounter, or is documented in a progress note indicating that the patient is treated or managed for the disease or condition during the measurement period. Thanks.
Thank you, Angie. The next question says, for Prev 12, does this mean the member does not need a depression diagnosis to qualify for the measure?
So the denominator of the Prev 12 measure is specific to patients who are age 12 years and older and who were screened for depression. There's a denominator exclusion for patients who have ever been diagnosed with depression or with bipolar disorder. So if those patients with a history of depression or with bipolar disorder should be excluded in order to capture those who are newly depressed with, or excuse me, newly diagnosed with depression, excuse me.
Thanks, Katie. The next question for HTN2, should blood pressure be taken and urgent care be used?
And this is Deb. Yes, you would use the most recent blood pressure documented during the measurement period. If the most recent blood pressure documented is from an urgent care visit, you should use that blood pressure as the coding for urgent care visits is included in the hypertension 2 measure. Blood pressures taken from an acute inpatient stay or an emergency department visit are not included. Thank you.
Thanks, Deb. And then another question for you, I believe, for HTN2, can the lowest diastolic and lowest systolic reading be taken from different days in visits?
Yes, that one is mine as well. I would recommend looking at page 6 of the posted specification, which does provide the following guidance. If there are multiple blood pressure readings on the same day, you can use the lowest systolic and the lowest diastolic reading as the most recent blood pressure reading, but you should not be taking blood pressure readings from different days and putting them together. Thank you.
Great. And one more for you, Deb. For HTN2, if the documentation for the diagnosis is just I-10 or I-10 hypertension, thus not specifying essential hypertension, should that be used to confirm the diagnosis?
And that answer is no, you should not be using coding alone to determine the diagnosis. You can use the coding along with medical record documentation, however, to confirm the diagnosis.
Great, thank you. One more question on Prev 12. After a depression screening, it is stated as minimal depression instead of a result like positive or negative. Would this result of minimal depression be considered a positive result?
So again, this would be an instance where, we can't advise specifically according to how you document. So that would really be up to the clinician's interpretation, whether that was considered a positive or negative result, and then your medical record documentation would need to support that information. Thank you.
The next question, Prev 10, tobacco use, screening, and cessation intervention. Is that enough if the EMR says only patient is a non-smoker, or does it have to include that it's tobacco?
Hi, this is Jamie with the PIMS team. Thanks for this question. Just wanted to let you know we can't really comment on how you would document this type of interaction with the patient within your specific EMR, but would just recommend that it is clear to those that would be submitting data within the web interface that it's meeting the intent of the measure. Thank you.
Great. And a follow-up question for Prev 12, which population counts towards the performance percentage?
I think that question is for Prev 10, and it's from Jason. Is that correct? Do I have the right question?
Yes.
Oh, thanks. I think, and Jason, if I'm not interpreting your question correctly, I believe you're speaking to like which performance rate we would use for benchmark. and that would be performance rate number 2. And this is the performance rate that's looking at those that were identified as tobacco users and received tobacco cessation intervention. This is the specific rate that we would use to benchmark. Let us know, Jason, if that's not your intent for that question, just please provide clarification. Thank you.
Great, and just a reminder for folks too, we do see, of course, folks are submitting questions through the Q&A box, but we are taking questions via the phone line as well. So you can go ahead and raise your hand and we can unmute your line. So Jason, if you do need more clarification, that's an option as well. And another question for HTN2, and Deb, this is a question for you. Under the guidance of the audit for numerator, it states do not include blood pressure readings, 1, taken during an acute inpatient stay or an ED visit, and 2, taken on the same day as a diagnostic test or diagnostic or therapeutic procedure that requires a change in diet or change in medication on one or more day before the day of the test or procedure. And the question is, what is considered therapeutic procedure?
Thank you. And I'm actually going to answer this one and another one. Basically, there is not a list of specific procedures. That was kind of another question in regards to this hypertension 2 measure. And basically, your therapeutic procedure is any clinical intervention or procedure that would adjust the patient's nutrition or medications that could impact the patient's blood pressure. So again, because there is not a definitive outline of what is considered a therapeutic procedure, this would be something you would want to look at your individual medical record documentation to make that determination. Thank you.
Great. And we do have a question for PREV 13. If the documented ASCVD and chart in statin but didn't bill an eligible code, does that count for denominator inclusion in numerator and compliance?
Hi, this is Katie. So it's not required that the codes have been billed. Your medical record documentation just needs to support the appropriate diagnosis for confirming the patient in the denominator. So if you have medical record documentation supporting the fact that they should be confirmed, then you would go ahead and include them, but it is not specific to billing codes. Thank you.
Great. And it looks like, Jason, we do see your hand is raised, so we will unmute your line and you can go ahead and ask your follow-up question. And you may be muted on your end as well, Jason.
Can you hear me?
Yes.
So I want to clarify, the person was saying that they're using, my question with PREV 10 is I wanted to make sure I understand the population that is used for performance. That may be the same as benchmark, but my question is what population is used to generate the performance score for PREV 10?
Hi, Jason. This is Jamie. Thank you so much for clarifying. I'm sorry I misinterpreted that question. That population that is being looked at within that particular performance rate for cessation are those patients that are identified as tobacco users. So once you, once you
tobacco users, not the population that are tobacco users and receive counseling?
Right. So once you screen your patient within performance rate 1, any of those that were found to be positive for tobacco use would be in 2, and then you would have to meet performance by providing cessation. You got it. That's correct.
Okay, but my question still is, like, which one of those is the performance? Is it, you're saying it's the stepwise for all 3?
So performance would be based on cessation counseling provided to those patients that are identified as tobacco users for performance rate.
All right, thank you.
You're welcome.
All Great. And we will shift back over to some other questions we've received. A few more on Prev 12. The next one, do we exclude patients who get a diagnosis of depression because of the screening?
Hi, this is Katie from the PIMS team. So no, the exclusion would be for people who were diagnosed prior to the performance period. Those who are newly identified as having depression during the performance period, the expectation for those patients is that you do document a follow-up plan as outlined in the measure specification. So if they are identified as having positive, or excuse me, if they screened positive for depression, they would need that follow-up plan. Those patients who have a history of depression or bipolar disorder would be excluded from the patient population. Thank you.
Thank you, Katie. And one more Prev 12 question. Does it have to be a PHQ-2, or can the provider document 2 questions that he asked be accepted?
Hi, yes, so I think this is related to whether the specific questions are written in an EHR, for example, or if it has to be specifically labeled with the screening name. And so again, I think this is just going to go back to the response that we can't advise you how to document in your medical record. You just need to be able to support that all of the components of the measure specification are met. This includes that the patient met the denominator criteria, the numerator quality action was performed, and any applicable denominator exclusions or exceptions existed. And we're also going to address this as it relates to a screening result of 0, if that can be considered negative. So we can't provide specific feedback whether or not any documentation, including those screenshots, scenarios, or internal policies would meet the intent of the measure. In all of those instances, you will just need to make sure you have all elements captured in your medical record. Thank you.
Great, thank you. And another question for Prev 12, depression screening, and it says, can we use the distress screening tool for oncology patients?
So the measure specification for this has a list of examples of depression screening tools that can be included, but the measure isn't limited to those specific screenings. So you would just need to ensure that whatever tools you are using meet the definition of a standardized depression screening tool as outlined on page 5 of the Prev 12 measure spec. And the definition is that it is a normalized and validated depression screening tool developed for the patient population in which it's being utilized. Thank you.
Great. And a question, if we can find major depression on an encounter 11/2020, but the patient didn't have a PHQ-9, is that patient still included in the denominator? Some of these patients come to the practice with the diagnosis, so they don't do the PHQ-9 in the time frame.
Hi, this is Angie. No, the patient has to have, I'm sorry, I'm losing track here. The patient has to be able to have both an encounter during the denominator identification period, as well as the PHQ-9 greater than 9 during that same time period in order to be included in the denominator. Thank you.
Great. Of course. And Angie, one more question for you. For MH1, does billing code need to be submitted the same day as you have an elevated PHQ-9 to get an index date, or if the patient has an ongoing depression diagnosis on the problem list, and then the index date would be first elevated PHQ-9?
So again, you have to have both in order to be in the denominator. You have to be able to identify your index event date. And so that's going to be the date of the encounter, of an encounter during that time period that is associated with the diagnosis of depression or dysthymia during that period. And then that marks the start of the patient's measurement period for or the index event date, yes, which marks the, I'm sorry, I'm having problems today. It both have to be present in order to be in the denominator. And at the time that the encounter is associated with the diagnosis, that would be the index event date. So they have to have both those things to be included in the measure. Thank you.
Great. A couple of other questions we received. Does a diagnosis of ASCVD need to be active during 2022, or would a diagnosis from 2018 count?
Hi, this is Katie. And just to clarify for those listening, this is in relation to Prep 13. So for denominator confirmation of population 1, you can determine if the patient has a diagnosis of ASCVD. This is inclusive of an active diagnosis or a history of ASCVD. So in this instance, it is asking about a diagnosis from 2018 would be included, and an active diagnosis from 2022 would also be included. Thank you.
Thank you, Katie. A couple of other questions for you. Does hyperlipemia count as needing a statin, or does it have to actually be familial or hypocholesterolemia?
Yes, so it does need to be specific to an active diagnosis of familial hypercholesterolemia. Hyperlipidemia isn't sufficient to confirm the patient in population 2 for Prep 13. Thank you.
Great. And then someone did ask for clarification and said, just to confirm, if the patient gets a diagnosis of depression as a result of the screening, for example, newly diagnosed, would we include them in the measure?
Hi, this is Katie again. So I believe this relates to Prep 12 again. So I've seen this question pop up a lot, so just want to try and clarify that all patients age 12 years and older should be screened for depression. That's the intent of the measure, but it is looking to exclude patients who have been diagnosed with depression or with bipolar disorder. So the measure is looking for patients newly diagnosed with depression during the measurement period. Thank you.
Great. And just another reminder, if you do want to ask a question via the phone audio, please go ahead and click that raise hand button and we will unmute your line. A few questions, and I think some folks have responded to them in the chat, but we did get a question that says, for the CARE2 web interface fall measure, if it is documented in the fields of the EMR gait assessment or fall screening tool that the patient is non-ambulatory, will that count as a fall screen?
And this is Deb. So the CARE2 measure specification does define a screening for future fall risk as an assessment of whether an individual has experienced a fall or problems with gait or balance. As long as your medical record supports that the patient was assessed for problems with gait or balance, the intent of the measure has been met. Per the numerator guidance in the 2022 CARE2 measure specifications, the following is included. The medical record must include documentation of the screening performed. Any history of fall screening during the measurement period is acceptable as meeting the intent of the measure. A gait or a balance assessment meets the intent of the measure. Thank you.
Thank you. And one more question for Care 2. If a patient was assessed for ambulate, yes or no, will that be considered an assessment for fall risk?
So if you're unsure of the documentation that you have and whether or not it meets the denominator requirements, it may be necessary to confirm with a clinician. Per page 8 of the specification, a gait or balance assessment does meet the intent of the measure. Also on page 5 of the Care 2 Falls Screening for Future Fall Risk Assessment, there is additional guidance. So I would recommend kind of looking at the specification. If there are, like I said, still questions about whether or not your documentation meets the requirement, we may not be able to answer that, as we don't have access, of course, to the full medical record documentation and would not be able to make that assessment. That would be something you would need to go back and possibly reach out to the clinician to confirm. But again, we can only point you to the medical record or to the specification itself and provide guidance based on what has been provided by the measure developers. Thank you.
Thank you. And it looks like we have a few folks with their hand raised, so we will switch now to take a few phone questions. Taylor Van de Velde, we will unmute your line, and you may have to unmute on your end as well, but you can go ahead and ask your question.
Thanks very much. I saw in the chat that there was a question about if Prev 12 moved to pay for performance instead of pay for reporting from previous years. And it looks like the question was answered that it is a scored measure for PY 2022. And I just wanted to make sure I understood that in saying that in my mind is a move to pay for performance, whereas previous years it was pay for reporting. So I was just looking for some clarification on that.
Yes, I can respond to that. This is Kara from RTI. You are correct in your understanding. To be consistent with MIPS reporting, there no longer is a pay for reporting option. Measures are rather scored or not scored, but Prev 12 being scored would be consistent with what we would have thought of as pay for performance in prior years.
Got it. Thank you.
Great. And Sarah, Brian, we will unmute your line and you can go ahead and ask your question as well. And it looked like she may have just lowered her hand. So Kelly, we will move on to you. Kelly Tadeo.
Hi, yes, I just had a quick question. For the hypertension measure, so if a patient does use a electronic device or a digital device to take their blood pressure reading, does it have to like transmit automatically, does it have to transmit that reading electronically to the provider to read? Or the guidance does say it's the clinician's responsibility to confirm if that remote monitoring device used to obtain the blood pressure is considered acceptable. So I guess I don't know okay.
Yeah, no, that's correct. It is ultimately up to the clinician who is taking responsibility for that blood pressure. As provided, certainly telehealth visits are acceptable. But I would say based on the measure specification, as long as you were following that and the clinician has determined that that blood pressure value is reliable and accurate, then it could be used.
Okay. Thank you.
Great. And Sarah, Brian, we will unmute your line and you can go ahead and ask your question as well.
Okay, can you guys hear me?
Yes, we can hear
you. Okay, awesome. So with the HTN2, it does say that we should count common low intensity or preventative procedures, and there's like a list of some examples that would count. We're just a little confused at my site because, like a chemo infusion day might be low intensity, but it's not common. Like a needle guided injection right into a joint is we think, relatively high intensity, but also one of the examples is an IUD insertion, and I'm not sure who decided that was not a high intensity procedure.
So this is Deb from the PIMS team. First, I would recommend you go ahead and open up a ServiceNow case. But one of the things that we can't speak to each of the procedures, unfortunately. As you saw in the specification, there is a non-exhaustive list. So it would be a situation where you certainly would want to use the medical record documentation along with the specification to determine if that blood pressure, and assuming it is considered the most recent blood pressure documented in the medical record, should be used.
Okay,
and then if there's nothing that precludes it, if the measure specification is kind of pointing you to that blood pressure should be used, and it's considered out of control, and you feel like there are circumstances that that it should not be included, it is at that point that you may want to consider requesting another CMS reason to skip that patient. Again, if the measure doesn't allow you to not use that most recent blood pressure, that would be the only other option.
Okay.
Okay. That is it for folks with their hands raised. So again, if you do want to ask a question live, please go ahead and raise your hand. But for now, we will switch back to those submitted through the Q&A box. Another question on Prev 12. If more than one are conducted during the measurement period, is there performance as to which encounter we use?
Hi, this is Katie. So the measure specifications do require that you use the most recent screening during the measurement period. So if there were multiple documented, you would use the most recent. Thank you.
Thank you, Katie. And we did receive a question on Prev 13. Does a patient need to have an eligible visit within the measurement period? And if so, can a telehealth visit qualify for that eligible visit?
Hi, so by virtue of being sampled into the web interface for this measure, the patient would have had at least one eligible encounter during the measurement period. But since this piece would be specific to that sampling step, I'm going to ask someone from RTI if you have more to add in regard to the encounters that are used for sampling for this measure.
So this is Kara from RTI. I would reference folks to look at the document on the QPP Resource Center that's titled Telehealth Guidance for Web Interface Reporting. That outlines which codes are used to identify telehealth visits. So, it depends. There are certain codes that are used to identify telehealth. There are also standard visit codes that can be billed with a telehealth modifier. So it really kind of depends on both the code and how it was billed. If you have more specific questions, I would suggest that you submit a help desk ticket, but many of your questions might be answered by looking at that guidance document. And we can post the link to that document in the Q&A.
Great, and we did get one more person with their hand raised. Zena, we will unmute your line and you can ask your question.
Yes, hi, can y'all hear me?
Yes, we can hear you.
Okay, great. Yeah, I posted this question in the chat, but it didn't get answered, but it was about Prev 12 denominator exclusion, just a clarification with this one. So will the new diagnosis of major depression or bipolar during the measurement year be acceptable as an exclusion? Or do we have to have documentation essentially that interventions have been made?
So we are actually going to suggest submitting a ticket to the help desk just so that we can do a little bit more digging into this specific scenario. So we would ask that you just send an email to qpp@cms.hhs.gov and include that this is for 2022 CMS Web Interface Measure 12. That might help it get routed a little faster, and then we can get back to you with an answer. Thank you.
Thank you, Katie. A question on Prev 12, if all 9 questions are listed and answered of the PHQ-9, but doesn't say PHQ-9, is that okay?
Hey, this is Katie. So this is another situation where we would just like to emphasize that we cannot provide specific feedback, whether or not documentation in the patient medical record, including screenshots, scenarios, or internal policies. How specifically you document is up to your organization, and you would need to ensure you're capturing all information related to the measure specification. Thank you.
Thank you. And Deb, a question for you. Can you repeat what was said about essential hypertension? If the code is hypertension I-10, what is encoding document? That does not count.
Yes, I will. I'm sorry if I caused any confusion. It's not that that code doesn't count. It's that when you are confirming a diagnosis, coding alone is not sufficient. You should have medical record documentation that supports that. So if you use the ICD-10 code to kind of help you find in the medical record where you can confirm that the diagnosis is appropriate per that measure, then you would be able to use those two things together. So again, I wasn't saying that the ICD-10 code is not appropriate. It's just that it cannot be used by itself to confirm the diagnosis.
Thank you, Deb. And one more for you. For HTN, is it for 18 and up, but the exclusion for frailty or dementia drug and advanced illness is for those over 66? How would someone who is younger be excluded, or would they not?
And for that one, they would not be excluded. So that frailty code is age specific. And as you noted in the question, the measure itself, the age range is beyond the age for the frailty code, for the frailty exclusion. So you would not be excluding patients younger for frailty purposes. Thank you.
Great, and we see Kelly has her hand raised. Again, Kelly, we will unmute your line and you can ask your question.
I think I got the answer. I just want to double check because one of our auditors we're doing a chart review. For mammograms, patient can self-report. We just have to put, or if it's in the chart that it's just documented they had in the mammogram with the result, that's enough. You don't need a copy of the actual mammogram from the clinic.
This is Deb, and the first Prev 10 question that I've answered in a long time, but I think that the bottom line is that you will, as long as you're following what is in the measure specification, what is being asked for, and your medical record documentation supports that, then that would be sufficient.
Okay, thank you.
You're welcome.
Great, and this might be related, but we do see in the chat there's a question on mammograms. It reads for Prev 5, if a mammogram is documented on a progress note, does bilateral need to be stated? For example, mammogram 12/31/22 normal, would this be acceptable for the measure?
Hi, this is Angie. Again, we can't really speak to exact documentation in the medical record, but the measure does define mammography, which is a screening of bilateral screening of both breasts. So that would be the norm. If only one breast is present, then there would need to be documentation, and the unilateral screening of one side must be performed on the remaining breast. So as long as you have documentation that a mammogram was performed, which is typically bilateral, that should be good to meet performance. Thank you.
Great. And a question for Prev 12, does the provider need to document the interpretation of negative or positive of the results, or can an eligible professional as defined by CMS as being someone that our organization deemed qualified interpret the results?
Hi, this is Katie. So you're correct that the measure specifications do state that the results must be reviewed and verified and documented by the eligible professional in the medical record. We just want to clarify that the intent of this statement is that the quality action should be completed by an eligible clinician. However, it is acceptable for others within your organization to complete the action. It can be completed by anyone that your organization deems qualified. Thank you.
Thank you. And a couple of other questions I know we've answered, but Prev 13 and MH1 are not scored. Is that correct?
This is Kara from RTI. That is correct.
Great. And one more question about MH1. Are MH1 and tobacco a pay for performance in 2022?
This is Sandra. MH1 is not scored. The tobacco screening measure is scored.
Thank you, Sandra. We did receive a question that says, is railroad retirement or Medicare considered a fee-for-service payer Medicare Advantage plan, or is it considered traditional Medicare?
This is Kara with RTI. Railroad insurance is considered fee-for-service Medicare, so it would not be a reason to exclude the beneficiary.
Great, and we will switch back over to the phone line. Zena, we see that you have your hand raised. We just unmuted your line and you should be able to ask your question.
Okay, great. Yeah, I just had another question about Prev 13 for the exception rules. So if a patient is intolerant to statin, can we consider that as an allergy to a statin medication?
Hi, this is Jamie. That's a great question. And what I would point back to is the denominator exceptions and the different conditions that are listed within those denominator exceptions. If you find that the intolerance is based on the premise that's found there or defined there, then it would be acceptable to report that patient as a denominator exception. But I would really lean into the definitions provided there.
Okay, and in the event that there's not any, if it's just a generic, the patient's intolerant to a statin without any additional signs or symptoms of why, is that acceptable?
So go ahead, Katie.
This is Katie. Sorry, I was just going to jump in and say one other thing that we would encourage you to do related to that question is to review the denominator exceptions in the Prev 13 coding document to see what's outlined as applicable there. And then if you have further questions, you can always send those to us through the help desk at qpp@cms.hhs.gov, and we can take a closer look at those with you too.
Thank you.
Thank you, and we'll switch back over to the Q&A box. But again, if you do want to ask a question live, please raise your hand. A couple of other questions. If the tobacco screening is done while a patient is admitted to our CAW ED, can we use this screening result to meet Prev 10?
Hi, this is Jamie. Absolutely, the tobacco Prev 10, that measure does not limit when cessation can occur. It just has to be documented within the appropriate timeframes as listed within the specification. Thanks for the question.
Great. And Katie, I know you did want to go back and revisit some questions that we've seen related to PREV 12 and new diagnosis of depression or bipolar disorder. So I will let you jump in there for some clarification.
Hi, yeah, so this was a question that's been asked in the chat and was asked live. I did refer it to the help desk, but we did find clarification in regard to the timing of those denominator exclusions. So for the patients with a history of depression or bipolar disorder, if you take a look at the measure specification for PREV 12 on page 9 under the denominator guidance, it does specify that this should be prior to any encounter during the measurement period. So those patients may be excluded if they were diagnosed with depression or bipolar disorder prior to any encounter during the measurement period. Thank you.
And Deb, a quick question for you in regards to the HTN measure. Can we accept a patient reported BP reading taken on an electronic or digital BP device by the patient in his or her home and reported verbally during a telehealth visit?
Thank you. I think there are several that are kind of getting at the same question. So hopefully this answers the question for several of you out there. So a blood pressure taken by either a clinician or a remote monitoring device, that being a home device or a device brought by a nurse, visiting nurse or caregiver, and conveyed by the nurse or caregiver or by the patient to their clinician is acceptable for the numerator, as long as it is the most recent blood pressure reading documented in the medical record for the patient during the measurement period. Since the measure guidance and specifications do not define what constitutes a remote monitoring device or methods of conveying the blood pressure from a remote monitoring device to the clinician, we are unable to provide guidance on specific devices or a specific workflow on how the clinician interacts with patients using that remote monitoring device during a telehealth encounter. And as we previously stated, it is at the clinician's discretion as to whether the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. Thank you.
Great, and turning back to the phone lines, Cindy Burton, we see that your hand is raised, so we will unmute your line and you can ask your question.
Hi, I want to make sure y'all can hear me.
Yes, we can hear you.
Okay, perfect. I just wanted to comment on the PREV 12 about the denominator guidance on page 9. It does say that the exclusion criteria must occur prior to any encounter in the measure period. However, I feel like the interpretation that you guys are given are that any encounter means the first encounter of the year, where I am interpreting that as meaning any encounter that occurs within the year. So can y'all please provide clarification on that?
Hi, this is Katie. I'm just gonna jump back into, so it does say prior to any encounter. One thing that we can do, again, is take this back from the intent. So we can keep digging into this just to make sure there is clarification. And then we can also add this, we can discuss this again on our next support call to make sure it's fully addressed for everyone. And then if you do want an individual response, we always encourage you to submit a help desk ticket. So again, that would be to qpp@cms.hhs.gov. Thank you.
Okay, thank
And Vina, we see your hand is raised again. Not sure if you had a follow-up question?
Yes, it was in regards to the same Prov 12. I know Katie, you mentioned that page 9, and the previous person just asked about this as well, about the denominator exclusion timing being prior to any encounter during the measurement period. But I just wanted to also address page 6, which states that patients who have ever been diagnosed with depression or bipolar disorder will be excluded from the measure. So I think that those two are kind of two statements that are contradictory to each other, and they're kind of causing some confusion for us. So clarification on that would be helpful. Thank you.
Yeah, thanks for the feedback, and we'll definitely take this back and do a little bit more digging just to make sure that we have a clear answer. Thank you.
Great, and turning back to some questions in the Q&A box. Jamie, this question for you is a follow-up question, but it says the frailty code is only found on the PET scan diagnosis and the patient is on a dementia medication.
Yep. Hey, thanks for pulling this back through. And thanks to the inquirer. I appreciate you giving me the time to get some clarity around your question. As far as meeting or having or requiring an encounter to determine or quantify if that patient meets the intent behind the denominator exclusion, you definitely don't need to have an encounter to do that. What I would recommend is that you go out to the coding document for DM2 and just reference that tab of denominator exclusions. And if your patient is meeting any of the codes that are found within that tab, then it would be appropriate to go ahead and remove that patient from your population and within the denominator. So hopefully that's clear. If not, please submit a ticket and we can chat this one out. I really appreciate it. Thank you.
Great. And Deb, a question for you for the hypertension screening. If a patient saw their PCP for their last visit of the year with a recorded BP, but it was for a sick visit, should we count that?
And yes, basically you should count the last documented blood pressure within the medical record, unless that blood pressure was taken at an acute inpatient stay or an emergency department visit. And those two, of course, are not included within the hypertension 2 measure. Thank you.
And Katie, a quick question for you. If a patient was in hospice at some time during the measurement period, but is removed from hospice, is that patient excluded or included for the measurement period?
Hi, so if a patient was in hospice care at any time during the measurement period, and this would include non-hospice patients receiving palliative care, goals, or comfort care, they would be considered not qualified for sample. So you would select that option if there's any documentation of them having hospice care during the measurement period. Thank you.
Thank you, Katie. And Deb, another quick question for you. Asking for clarification, it says some EMRs have different naming for ICD-10 codes. For HTN2, if the progress note says hypertension in I-10 versus essential hypertension in I-10, would the first still count? Does it need to say essential hypertension, or is hypertension good enough for denominator inclusion?
So what you want to be able to do, and of course this is to your benefit to confirm, not only is it needed, but to your benefit to confirm that the patient that is included in the denominator really should be included within that denominator. So the guidance that we are providing is you can use the appropriate codes to help you find the documentation within the medical record that supports confirmation of a diagnosis. If there is verbiage that might be missing from the medical record documentation, but you can use both the verbiage that you have, what is documented, along with the appropriate coding, you can use those two things together for confirmation. I hope that helps. If it doesn't and you have some additional questions in regards to that, then either ask another question, or you could also, as we've provided earlier, you could certainly open up a ServiceNow case and we can provide you some written documentation to your questions. Thank you.
Thank you. One more question we received: will the CMS Web Interface sampling templates that are posted to the QPP library be updated?
Hi, this is Katie. I do want to note that the Excel template and the Excel template with sample data were updated on the QPP resource library as of January 19th. So if you go out there, and I think the easiest way easiest way to find them might just be to search template. Those will come up with the updated versions. Thank you.
Thank you, Katie. And Angie, one question for you. For MH1, is there a CMS calculator tool to automatically calculate the year plus or minus 60 days? And for depression remission, is the 60 days plus or minus specific to the date or specific to the 2 months?
First of all, no, there is no CMS calculator tool to calculate that time frame. And if the patient had one or more PHQ-9s or PHQ-9Ms administered during the measure assessment period, which is 12 months plus or minus 60 days, and that is from the index event date. Thank you. I wanted to make sure I answered everything. Thanks a lot.
Of course. And it looks like we don't have any other questions. So again, if you would like to ask a question via the phone audio, please go ahead and raise your hand, and we'll unmute your line and you can ask that question live, or submit some questions through the Q&A box. We will give it just another minute. I know some folks are still submitting questions. And Jamie, we did just have a question come through. Can a patient self-report their A1C results if the provide date of test for diabetic measure?
Hi, thanks for submitting this question. We actually just received this through the help desk last week, so I'm going to go ahead and read that response that we provided. The measure specification doesn't provide detailed information on what can be obtained during a telehealth encounter for the purposes of the 2022 performance or measurement period in regard to this measure. But what you can do is the reason for that is the flexibility for that interaction between the patient and that clinician. We want to make sure that we're trying to communicate a concept that works for all possible workflows, and trying to, get that documentation in place. What we would point to is the guidance in the numerator, as it does provide a hierarchy available for that type of information that needs to be documented within the medical record to meet the intent of this measure. I'm going to go ahead, actually, because that was not my best response today. I'm going to copy out what we provided within that help desk ticket within that chat, but thank you so much for the question.
Thank you, Jamie. And Deb, another question for you on HTN2, just saying, I believe it was in measure guidance, but if a provider documents a patient as having primary hypertension, is that considered the same as essential hypertension?
Yes, so if you were to refer to page 9 of the posted specification, it's actually the first note on page 9. And it does state that essential hypertension is high blood pressure that doesn't have a known secondary cause. It is also referred to as primary hypertension. Thank you.
Thanks, Deb. And again, just a reminder, I know we have a few minutes left. If you would like to ask a question live, please go ahead and raise your hand or submit questions via the Q&A box. We'll give it just another minute for folks if they have questions to submit. Okay. Well, Dan, we will go ahead and turn it back to you to conclude today's webinar.
Thank you, Olivia. So thank you all for joining us today. Just as a reminder, the slide deck, recording, and the transcript from today's call will be available on the QPU webinar library in the next 2 weeks. And reminder that our next support call is scheduled for Wednesday, February 8th from 1 to 2:30 p.m. Eastern Time, during which we'll cover frequently asked measure questions regarding DM2 and Prev 13. We hope you'll join us. Thanks for participating today.